कि ये पुणे में इनफर्टिलिटी स्पेशलिस्ट है, रोज एक दो वेबिनार ही होते हैं इसके। और ये अभी वाला जो है ये तो समझ में आ रहा है किसी दुबई के डॉक्टर से, मतलब सऊदी वाले। जाऊं
अच्छा, you can start. Okay. Hello everyone. I hope my slides are clear.
Yes, clear.
Yeah. Okay. Thank you.
Doctor, we make all the participants muted for not interrupting you. After the lecture after you end the lecture, we can open them their mics.
Okay. So I'm starting.
Okay. You can start, doctor, if you want.
Okay. Voice is thing. Request to all other persons, please mute yourselves. Yes, all are mute. As voice is echoing, so please request to everyone, please mute themselves. I think now.
All the participants are muted now, doctor. Please not unmute yourself if it's possible for you.
So I'm starting my presentation now. So friends, here I am Dr. Ritu Santhwani this side, Director Shamwell Women Clinic, Pune Test Tube Baby Center. Friends, I believe on the concept that knowledge is always increases by sharing. So do connect with me on all the social media platforms. I am here on the YouTube, LinkedIn, Facebook, Instagram. Do connect with me and we will change our thoughts. So we can increase our knowledge in this lockdown time also. As our India, why to say the India? Everyone is going now in this time with the second phase of the corona. So we have to stay at home, but we have to stay connected. So yes, of course, we doctors, we have to go for and see the patients and operate the patients. But rest of the time when we are at the home, I think this is the best time we can utilize our time by gaining more and more knowledge. So I always start my presentation by giving some tribute and giving some vandana to my Mata Rani, to my goddess. Friends, these two lines in the Sanskrit. So, Ya Devi Sarvabhuteshu Chikitsa Rupen Sanstita Namastasei 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 Namo Nama. So, namaste to my all of the friends who have joined from the India, and salam alaikum to all the friends who have joined from the Arab countries. Thank you to my great friend Dr. Shadi Salim for inviting me here. Together we have done a lot of successful webinars. These are the clipping of some of the webinars. So friends, here is the curtain raiser for our upcoming program, the academic marathon, all about the infertility. On this Sunday, 9th May 21, we are organizing. So all of you are invited for this, because knowledge is again and again increase as much as the discussion we do. So now coming to the today's topic, the topic which I'm going to discuss today is the chronic pelvic pain. So as we know, this chronic pelvic pain in the woman is defined as persistent non-cyclic pain perceived to be in structures related to the pelvis and lasting for more than 6 months. So now how I'm coming into the categories. Now first I'm going to discuss about the introduction. So the chronic pelvic pain, however, should be considered a symptom rather than a diagnosis, and there is debate as to what the precise definition should be. Recent European guidelines recognize a more encompassing view of chronic pain and state that it is perceived to arise from the structures related to the pelvis and is often associated with negative cognitive, behavioral, sexual, and emotional consequences, as well as with the symptoms suggestive of lower urinary tract, sexual, bowel, pelvic floor, or gynecological dysfunction. So many times we are seeing the patients in our OPD are coming that, ma'am, we are suffering from this chronic pelvic pain from the years, from the yesterday only I saw the one patient. The patient told me, ma'am, I am suffering from this pelvic pain from more than 6 years. Because where I practice in the Pune is the metro city, I am getting all the patients who are a Google savvy. So the yesterday patient, what I have seen, the patient only herself told me, ma'am, I have done everything. I have done so many times my urinary tract examination. The patient herself has done the urine routine, urine culture. Patient has done the uroflowmetry too. Now coming one by one to this. So as we all know, this chronic pelvic pain is still the enigma. So a very famous quote that 20 years ago, I would have told you that I knew everything, and that was to know about the pelvic pain. 10 years ago, I would have told you that no one knew anything about the pelvic pain. Today, I can tell you that we have learned a lot in the last few years. There is still a great deal to be learned. So the chronic pelvic pain has a major impact on the woman's lives. Females with chronic pelvic pain report a lower quality of life with higher rates of functional impairment, psychosocial distress, and sexual dysfunction. Economic cost associated with chronic pelvic pain, both for the patient and the wider healthcare system in society. Women are often prescribed inappropriate analgesics such as opioids, which does not address the underlying cause and can be associated with adverse effects. So this study I have got from this PubMed study, which is supporting for this chronic pelvic pain in women, as you just discussed, a non-cyclical pain perceived to be the structures related to the pelvis and lasting for more than 6 months. So women experiences of living with chronic pelvic pain, mostly the patient comes with the complaints of, I do not know if my pain is abnormal or whether this is normal for women. I'm embarrassed to talk about my pelvic pain to others. People will think I am just moaning. I need to know that what is causing my pain and so that others believe me. My doctor does not listen to me or believe me because even though I am getting nowhere, I keep going back. These are the usual common symptoms of the patients with the chronic pelvic pain. So now what are the 4 key themes have been identified that are important for the woman with chronic pelvic pain? So we take one by one. First, to receive the personal care by a supportive and understanding healthcare team. Second, to be taken seriously as a patient with genuine pain. Third, to be given as an explanation as much as cure, both for women with or without identified pathology. Fourth, to be reassured that the pain is not caused by cancer, that the pain can be treated, and that other women experiences the similar pain. So now, what is the epidemiology? This is the quote from the BMC Public Health Journal. They have reported a systemic review of high quality studies by WHO in 2006 found the prevalence to range from approximately 2.1% to 24% for the non-cyclical pain, 8% to 21.1% for the dyspareunia, and 16.8 to 81% for the dysmenorrhea. Here we can see the maximum range is for 16.8 to 81% has been reported for dysmenorrhea. Then an updated review published in 2014 used a more stringent definition for this non-cyclical pain lasting at least for 6 months and found the prevalence estimates that range from 5.7% to 26.6%. Physiology of this pain. The pelvic pain may be either visceral splanchnic pain, parietal somatic pain, or the referred pain. And this pelvic pain may be either nociceptive or the neuropathic. So now coming to this, what's the nerve supply of this pelvic organs? I think this is a very, very important. So the pelvic organ nerve supply, we can go one by one. The autonomic nerve supply, the sympathetic nerve supply is T10, 11, 12 and L1, while the parasympathetic nerves S2, 3, 4. And the somatic nerve supply is via pudendal nerve S2, 3, 4. So the distribution to all the pelvic viscera supplied by the visceral afferent fibers S2, 3, 4, the pelvic splanchnic nerve, and the referred pain referred to the area of the perineum, while the exceptions is the anal canal below the pectinate line and the ovary T10, T11, and the uterine body and fundus T10 and L1 to the lower abdomen. So I think this is very, very important. When we are in our UGs, this is a very, very important questions for our practical examinations in the Viva. So now what is the diagnostic dilemmas for this chronic pelvic pain? So the frustration is for both, for the patient and for the doctor. So disability and distress significantly cost to health services around 8 billion up to the studies have been reported. So now what are the conditions that may cause or contribute to chronic pelvic pain in women? The gynecological conditions, endometriosis, adenomyosis, adhesions, secondary to infection or surgery, chronic pelvic inflammatory disease, pelvic organ prolapse, pelvic congestion syndrome, benign tumors, uterine, ovarian, vulval or vaginal pain syndrome, ovarian remnant syndrome, trapped ovary syndrome. Then coming, what are the GI causes, the gastrointestinal causes which are contributing for this chronic pelvic pain is the constipation, irritable bowel syndrome, inflammatory bowel disease, diverticulitis, diverticulosis, chronic appendicitis or Meckel's diverticulum or the adhesions. While coming to this urological causes, the bladder pain syndrome, the interstitial cystitis or the urethral pain syndrome. Continuing to this, the other causes coming to this, the neuromuscular and the psychological. Among the neuromuscular causes, some patients may complain that trauma secondary to vaginal delivery. The patients complain that after my deliveries, ma'am, I am suffering from this chronic pelvic pain. Surgery, that in this, any abdominal wall incision, including the cesarean section, or the pelvic floor muscle pain syndrome, vaginal muscle spasm, neuralgia from nerve entrapment or irritation, pain arising from the lower part of the spine, or the sacroiliac joint dysfunction, pubic symphysis dysfunction, coccygeal pain, piriformis syndrome, myofascial pain syndrome, and abdominal migraine. Coming to this psychological causes, among this, the depression, anxiety, or history of sexual abuse has been reported. Now coming to a very important entity for this pelvic congestion syndrome. So this pelvic congestion syndrome is associated with pelvic varicosities that results in a chronic pelvic pain, especially in the setting of the prolonged standing, coitus, menstruation, and pregnancy. This pelvic congestion syndrome affects the multiparous women of reproductive age group. The studies have shown most of the females are present with non-cyclical lower abdominal or pelvic pain, which usually described as a dull ache or fullness that persists for 4 to 6 months. The pain is often exacerbated by prolonged standing, coitus, menstruation, and pregnancy, and the associated symptoms are non-specific, including the headache, bloating, nausea, vaginal discharge, vulvar swelling, feeling of leg fullness, lower backache, rectal discomfort, urinary urgency, and generalized lethargy and depression. These are the common presentations. With this, especially the patients are presenting to the OPD with this generalized lethargy and the depression and lower backache. These are the some very common complaints in the patients with chronic pelvic pain of this pelvic congestion syndrome. So we can diagnose. There is a picture of this female with chronic pelvic pain syndrome, and here we can see the transvaginal sonography have shown the engorgement of the veins surrounding the left ovary, and plus in the CT scan also the enlarged left gonadal vein is seen. So now coming to this diagnosis, so the transuterine venography is the standard for diagnosis. Ultrasound, Doppler, and laparoscopy may reveal the varicosities. The treatment portion coming for this pelvic congestion syndrome, the medical in this the suppressive therapy or the low estrogen and high dose progesterone OCPs and the GnRH agonist have been reported. Among the next is the medroxyprogesterone acetate, 50 to 300 mg per day for up to 18 months. Studies have been reported. Coming to this venoactive drugs, a very important here, what we are using is micronized purified flavonoid fraction. We are giving this 500 mg twice daily for 6 months. It has a protective and tonic effect on the venous and capillary wall. So it increases the venous tone, improvement in lymphatic drainage, and a reduction in capillary hyperpermeability, ameliorate the venous stasis, statically significant improvement in pelvic pain scores without any side effects. Dihydroergotamine is also been reported, a selective venoconstricting agent which increases the venous tone and mobilizes the blood which is present in the capacitance vessels. Again, other is coming the surgical or the embolization. Then coming to the psychotherapy, explanation, reassurance that she is normal with some other sedative drugs. Now coming that what is in the differential diagnosis of this pelvic pain. So as we have just discussed, the gynecological causes in this coming one by one, either is maybe due to endometriosis or due to adhesions, the chronic PID, or due to this fibroids or adenomyosis or pelvic congestion syndrome. While among this GI causes, irritable bowel syndrome, chronic appendicitis, inflammatory bowel disease, diverticulosis, diverticulitis, and the Meckel's diverticulum has been reported. Among these urological causes in the differential diagnosis, the abnormal bladder function, detrusor instability, urethral syndrome, the chronic urethritis, interstitial cystitis, psychosexual function, dysfunction or abuse. While coming to this psychological In this, the depression, somatization, and the personality disorders has been reported. Friends, this topic of chronic pelvic pain is very, very vast. As much as possible, I try to include in this talk. So now coming to the other causes of this chronic pelvic pain in the differential diagnosis is the musculoskeletal causes, in which the nerve entrapment, neuritis, appendicitis, fasciitis, scoliosis, disc disease, spondylolisthesis, osteitis pubis has been reported. Among the surgical causes, the hernia, bowel disease, or the Addison's disease has also been reported. Coming to this for this urethral syndrome, in which